Well, thank you. My name is Erin Bahula, and I am a cardiac intensivist at the Brigham and Women's Hospital and an instructor of medicine at Harvard Medical School, and then an investigator at the TIMI study group, where we do large cardiovascular outcomes trials. And today I'd like to speak to you about the cardiac complications of COVID-19. I have no relevant disclosures related to this topic. So I think the first thing that's important to note is that clearly this is a rapidly evolving story. Since its discovery of COVID-19 in December, we've rapidly amassed a ton of data. As you can see shown here, we have now more than 25,000 publications that we've accumulated over really just 6 short months. So the story is changing and evolving very quickly. So it's just worth realizing that we don't have all the answers, but we are gaining some more insights. And so today what we'll talk about is the specific learning objectives are to review the epidemiology of the cardiovascular complications of COVID-19 as we understand it today, and then also to discuss the range of possible mechanisms for cardiovascular injury. We'll start with a case of an elderly gentleman that I saw in the Brigham and Women's Cardiac ICU. He was 87, and he actually was a very healthy 87, really just had a history of hypertension. And he was admitted with 1 week of fevers, shortness of breath, and cough. And on initial evaluation was somewhat hypoxic. His oxygen saturations were 92% on room air, which really by most definitions makes him a severe case of COVID-19 right up front. His workup when he presented was notable for infiltrates on his chest x-ray. He did in fact test positive for COVID-19 with an RT-PCR. And then he had many of the typical lab abnormalities that we see. So he had lymphopenia, he had an elevated lactate dehydrogenase, elevated coagulation parameters with an elevated D-dimer, elevated inflammatory markers, ferritin, C-reactive protein, and then also some indications of either cardiovascular stress or injury with an NT-proBNP and troponin that was elevated. Because of a concern for possible superimposed pneumonia, he was started on antibiotics and he was admitted, and he was doing well on supplemental oxygen on the floor for the first day. However, on hospital day 2, he acutely developed increased work of breathing, and he was also hypertensive and tachycardic. And the team on the floor got an EKG, which is shown here, which, as I mentioned, demonstrates tachycardia, but very notably, I didn't show you his baseline EKG, but his baseline EKG was normal. And here he has diffuse ST elevations, really through most leads on this EKG, with obviously some artifact there. And so we'll come back to discuss, how his situation evolved over the course of his care. But we'll pause to talk a little bit about COVID-19 in general. And I think one of the important take-homes is what we've realized is that most cases are not like his. Most cases, in fact, are mild. And this is data coming out of China, very large sample set, which suggests that probably at least 80% of cases are mild, and that probably many more are asymptomatic. And so those patients who develop critical disease is not very high. In fact, it's fairly uncommon, but when they have it, their prognosis is poor. So in this particular report, those with critical illness, so requiring ICU, mechanical ventilation, their case fatality rate was 49%, so very significant. And the question is really who develops that severe or critical of COVID-19? And what we've learned from a number of different case reports and case series, both in China and now throughout the US and Europe, is that patients who are either older or who have baseline comorbidities are more likely to develop more severe complications, so acute respiratory distress syndrome. They're more likely to have critical disease and require ICU level of care. And they're also more likely to succumb to COVID-19 or to die of the disease. And specifically, some of the comorbidities that we've recognized as risk factors includes older age, hypertension, diabetes, baseline cardiovascular disease, baseline lung disease, obesity, and also malignancy. There's a number of different things that we've recognized as risk factors. And An interesting part of the virology that we've, I think, all spent a lot of time thinking about is what is really the mechanism of injury with this disease. And early on, it was recognized that there is a protein on the surface of our cells, ACE2 receptor, which actually works out that it is the functional receptor for viral entry into our cells. And so the thought being that probably some of the injury that we sustain with this disease may be related to direct viral toxicity on various organs. And so we know that the manifestations of this disease oftentimes are respiratory. Those are the sort of the earliest. But that can progress to more severe respiratory manifestations with acute respiratory distress syndrome. And as shown depicted on this figure, the lung in fact does express high levels of ACE2 receptors. You can see acute liver injury where there is some expression, and acute kidney injury where again we do see expression of ACE2 receptor. And importantly, the heart also has ACE2 receptors, and one of the areas where I'll talk through that, but it does appear that endothelial cells have expression of ACE2 receptors. So let's move from what can be, as I mentioned, a multi-organ process, maybe initially manifesting as respiratory dysfunction, but may progress to involve other organs. And that also includes the cardiovascular system. And so we do see a wide array of cardiovascular complications. Much of the data that I'm showing you here in this table was pulled from reports of patients who were hospitalized in China. And I will say that these are the sort of early rates that were reported, and I know there's a lot of data looking into in subsequent reports whether or not this incidence actually holds true. But really, the first manifestation that was reported was something that they termed acute cardiac injury, which was defined by either a positive troponin, an abnormal EKG, or an abnormal echocardiogram. And in hospitalized patients across multiple different reports, it ranged anywhere between 7 to 28% of patients experienced this endpoint of acute cardiac injury. And certainly the incidence was higher in patients with more severe disease requiring ICU level care or who ultimately succumbed to the disease. There was one report that suggested that heart failure may occur as often as 23% in hospitalized patients, and at times that manifest as more severe forms with cardiogenic shock and at higher rates in non-survivors. There were a couple of reports that suggested that arrhythmias can occur, and we see as a broad range. It can be bradyarrhythmias, tachyarrhythmias. There was a subsequent report to the initial, which suggested that in all comers who were hospitalized, 17% had some sort of arrhythmia. There was a follow-up report that suggested that about 6% of patients experience a VT or VF event. So also does not appear to be uncommon. And what has been recognized more recently is thromboembolic events. And what I'm showing you here are data from ICU level patients who experience venous thrombotic events ranging anywhere between 17 and 69%. And we will talk about this in much more detail upcoming. And I'll break down the rates and the concerns there. Importantly, what we still don't know is really the time course of these manifestations. In many cases, they did not describe the severity of these manifestations and whether or not there was associated structural issues. So for example, LV dysfunction. There also is really limited data on predictors of patients who will ultimately develop adverse cardiovascular outcomes. And we certainly do not have data at the moment on really the mid-range or long-term outcomes. Most of the data we have is on how patients fared in that index hospitalization, but not on follow-up for those who survived. So that is still data that we really do need to collect. It's very important to our understanding. One thing we do appreciate, though, from several different reports is that those patients who have cardiovascular manifestations, so for example, those who have acute cardiac injury with a positive troponin, tend to have worse outcomes. And so this was a report looking at patients who had elevated troponins as compared to those who did not have elevated troponin. And the panel on the left shows that those patients who were admitted with a positive troponin, so above the 99th percentile, and that's those top two lines, tended to have worse mortality, so higher mortality than those who were admitted with normal troponin. And for when they followed these patients over the course of their hospitalizations, those who had increasing troponin over the course of time also tended to do worse. So again, if somebody experienced a cardiovascular complication, the outcomes are generally worse. And this was also suggested by one report that was looking at independent predictors of mortality. Now, we talked not long ago about some of the comorbidities that drive worse outcomes in patients, on a sort of univariable look. And we said that things like age, pre-existing cardiovascular disease, diabetes, all appear to increase risk. But when you look at a multivariable analysis and say, well, are those independent? In this one, it wasn't. It was really those people who ultimately experienced complications, so severe respiratory complications with acute respiratory distress syndrome or cardiac injury, who ultimately had lower survival rates in an independent fashion. And there's not been a lot of data out there about the cause of death in patients who ultimately die of COVID-19, but there is this small case series of about 70 patients where they looked at the mechanism or the cause of death in patients who had COVID-19. And sort of surprisingly, about 40% of deaths were attributed to some cardiovascular cause. Now, 33% of those were with concomitant respiratory failure, but 7% were solely related to cardiac cause of death. And then, as we might predict, the majority of patients ultimately died of some respiratory failure issue. So clearly, cardiovascular manifestations are important, and they really tell us a lot about the prognosis of our patients. So now let's dig into what the mechanism of myocardial injury might be. And what I'll say up front is that it probably is, there probably are multiple mechanisms that are at play. And not to say that every patient has every mechanism, but there probably is, it's probably multifactorial. And so we'll go through this figure in a little bit of a stepwise fashion. We know that many of our patients come in with pre-existing atherosclerotic disease, and then clearly it is a severe illness that they can develop. And so they're really a setup for demand ischemia. And, it's things like the hypoxia, the really aggressive fevers that many of our patients have. Some of them experience hypotension, and that's on the background, again, in many cases of pre-existing atherosclerotic disease, that they are very prone to having demand ischemia. Additionally, we suspect that there is acute coronary syndrome, so your run-of-the-mill epicardial plaque rupture events that can occur in the setting of COVID-19. And I think this is not too much of a surprise to us because we have previously and historically seen an association between viral pneumonias and viral illnesses and acute coronary syndrome. So the data I'm showing you here is from a study looking at influenza and the association between influenza illness and myocardial infarction. And what the authors did is they looked at the incidence of MI within around 7 days following the diagnosis of influenza, and found that there was a 6-fold increase in incidence of MI as compared to the 2 years surrounding that diagnosis of influenza. As we might expect, although we don't have a great sense of what the incidence of ST elevation or of ACS is in the setting of COVID, that it happens. So there's a report that I'm showing you here that was out of New York City, that they have several, really a case series of patients with ST elevation MI. And in a subset of them, 9 of them, they did angiography, and 2/3 of those patients then ultimately had thrombotic culprit lesions that are sort of classic for acute coronary syndrome. So it certainly happens. The incidence is not clear as of yet. Another potential etiology on top of demand ischemia and acute coronary syndrome is myocarditis. Now, myocarditis, when I say that, I'm thinking of a myocarditis-like syndrome where we have a troponin elevation, so evidence of myocyte necrosis, and oftentimes some depression of the left ventricular function. And I think that there are probably multiple things that could be at play here to drive this myocarditis-like syndrome that we're seeing. First, there is the potential for direct viral cardiomyocyte toxicity. Secondly, as I mentioned, there are ACE2 receptors on the endothelial cells, and so it is reasonable to hypothesize that there would be vascular endothelial injury and potentially vasculitis that would drive some myocardial injury. And then finally, we'll talk about this in much more detail. COVID-19 is a prothrombotic disease. And so we do believe that we're seeing microthrombotic events, which could also lead to myocarditis. And in fact, there are now some case reports out there suggesting multiple of these different mechanisms. So the first I'm showing you is of a patient who had cardiogenic shock. They ultimately did an endomyocardial biopsy, which found lymphocyte infiltration, which is very classic for lymphocyte myocarditis or lymphocytic myocarditis. And they were unable to detect any of the virus in the heart. So interestingly, it was really looked like a lymphocytic myocarditis without virus. And the MRI was fairly classic for the inflammation that you see in the setting of myocarditis. In addition, there was another case report where rather than seeing a lymphocytic infiltration, they in fact saw macrophages in the heart. And those macrophages actually had viral particles within them. And so here's a very different sort of microscopic presentation of myocarditis. Again, similarly clinical presentation of shock, cardiogenic shock. And then the third piece, which is interesting, is we're starting to see reports from autopsy series of both macro and micro thrombotic events. So I'm showing you pictures of lungs here with clot in it, and then on the bottom panel B is of microthrombotic events, and this is specifically within the lungs. But I think it's reasonable to suspect that we may be seeing some similar entity in the heart. And interestingly, in some of these reports, we're seeing that they're identifying certain types of cells, namely megakaryocytes in those organs, which makes us think that, in fact, maybe there's some platelet-mediated issue that we're observing. Another sort of interesting hypothesis comes from this and other reports. This was a report where they looked at individual cells from the heart, and they tried to determine the level of ACE2 receptor expression. And in fact, in this study, they did not see much expression in the cardiomyocytes. So we talked about direct viral cardiomyocyte toxicity. Well, at least here, this report wouldn't suggest that that should be. If we're talking about a viral entry into the cell as the mediator of injury, this would suggest that we shouldn't see that. But where we did in fact see high levels of expression was in the pericytes. And just as a reminder, which I needed, what a pericyte is, it's a cell type that really supports the microvasculature or the capillaries. And sort of maintains microvascular health. And so the thought here and the hypothesis is that you may in fact see infection of the pericytes, which then could lead to capillary endothelial cell death and microvascular dysfunction, and then subsequently myocyte necrosis as a result of that. So some sort of interesting hypothesis generating data that we're seeing there. So we've talked about now demand ischemia, ACS, and myocarditis, and I think the last bin is the sort of grab bag of stress cardiomyopathy or cytokine mediated, or really an inflammatory cardiomyopathy, which I think we believe that we see oftentimes in the setting of other infections like sepsis. And interestingly, what has led us to think about this specific entity is reports from China, very early reports where they looked at various biomarkers over time. And this particular analysis stratified by survivors and non-survivors. So survivors are in blue and non-survivors are in red. And what we see is that the coagulopathy markers like D-dimer rises in non-survivors over time. We've already talked about the troponin elevation, which is that panel E, which portends worse outcome, and that really is a nice demonstration of it in that figure. And then what I'll draw your attention to is the bottom two panels, so C and D. where they're looking at IL-6 and serum ferritin as markers of inflammation. And we also see that those markers of inflammation increase over the course of illness in those patients who have more severe disease. So that observation of the inflammatory response in patients with more severe disease has really led to the hypothesis that, in fact, COVID-19 in some patients may be a multi-phase or multi-stage disease, where there is an early stage where you have viral replication, and that's manifest as constitutional symptoms, maybe fever. And then you might have a second stage, which is more of a pulmonary phase, where you have, some of the infiltrates that we've observed on chest X-ray, some shortness of breath, some hypoxia. And it's during that period where hopefully your immune system gets control of this illness and that it's a productive response. But in some patients, there may in fact be a hyperinflammatory response where rather than being productive, it's actually pathologic. And it is that hyperinflammatory response by the host that actually drives some of the late organ dysfunction that we see. So for example, acute respiratory stress disorder or the cardiomyopathy and myocardial injury. And that may, if this theory is correct, inform how we manage these patients. So you would imagine, for example, that antiviral therapy or anything that's targeted at sort of preventing viral replication might be useful throughout the course of the disease, but that anti-inflammatory therapies, targeted anti-inflammatory therapies, might be more useful as you start to move into the later stages of the disease. But I think that is a theory, and it remains to be determined whether that's in fact true. So we will go back to our case now. Our 87-year-old gentleman who came in with COVID pneumonia up front and then developed acutely worsened work of breathing, and then also those diffuse ST elevations. So on the floor, they did a point of care ultrasound echocardiogram, and they noted diffuse ventricular dysfunction. He did actually rapidly progress, with hypotension, requiring high dose vasopressors and also intubation for increased work of breathing and hypoxia. And when I received him in the ICU, his EKG was so diffusely abnormal, it really did not point to an ACS event or a focal plaque rupture event. And so rather than taking him to an invasive angiography, we actually did coronary CT, which amazingly in this 87-year-old demonstrated virtually no coronary disease. And you can see the picture, the imaging on the right is actually from his coronary CT, where you get a sense that the base is moving not perfectly, but better than the apex is. It really sort of has a look of a Takotsubo or a stress cardiomyopathy. We did not pursue a myocardial biopsy or cardiac MRI because my differential in this case was either stress cardiomyopathy or myocarditis, and I thought I would treat both similarly, so I didn't pursue any other imaging. His course was interesting. Over the next 24 hours, he did have a large increase in his troponin. His BNP also shot up in the setting of his shock. And even his procalcitonin went from, I think, something like maybe 0.2 up to 30. We gave him full dose anticoagulation because of his apical hypokinesis and aspirin. And then something which was a little bit out of the box, but I did give him steroids at that time. It was not a part of our algorithm at the hospital, but again, just sort of thinking about what the underlying mechanism might be here, I decided to give him steroids, which we are learning now may in fact actually have been a reasonable thing to contemplate in this patient. He actually did quite well, and he was weaned off vasopressors within a matter of a couple of days. And really his LV function normalized very rapidly, again, within a couple of days. He was ultimately extubated, and I will show you in just a minute what happened. So like I said, I think the differential here was either stress cardiomyopathy or myocarditis. And fortunately for him, our patient was discharged to home. So that's a video of a patient being discharged from our institution. I think many institutions are doing this, where they announce something over the loudspeaker. In our case, it's Operation Hope, and then they tell us the location of where the patient's leaving the hospital from, 75 Francis Street. And it's really quite moving. Everybody comes to that exit and wishes them well. And so this 87-year-old made it out of the hospital after about a 4-week hospitalization, which we were all quite pleased with. So in the last little bit, I'll talk to you about treatment. We talked about the complications and specifically things like cardiac injury, heart failure, shock, myocarditis. We'll touch on thrombosis after this. But the treatment, I think, is really what we don't know very much about. I think we generally all agree that we should manage these patients as we would other patients. So if you have somebody with cardiogenic shock, use inotropes, use diuretics as you need to. Somebody with heart failure, we would apply our usual goal-directed medical therapy. And if somebody has really profound shock, consider mechanical circulatory support. We are learning a bit more about other COVID-specific therapies like antivirals. We know now that remdesivir is useful to limit the duration of symptoms in patients and potentially to improve mortality. We don't know whether that prevents cardiovascular complications. We have some early preliminary data about anti-inflammatories with the press release about dexamethasone. And again, that seems to help in terms of general mortality. I don't know whether that prevents cardiovascular manifestations. One very hot area of discussion and study is about therapeutic anticoagulation, and that's specifically as prophylaxis in patients who don't have an indication for therapeutic anticoagulation otherwise. And the rationale for this being of particular interest is that we now are recognizing that these patients are very prothrombotic and that they do in fact have both venous and arterial thrombotic events, and particularly high rates in ICU patients, which are the patients that I see when I'm in the ICU, which is where I spend all of my clinical time. We're trying to learn about the incidence. There is certainly variability in the reports that are published. It depends a little bit probably on background therapy and what degree of prophylactic anticoagulation they were on, and then also what degree of surveillance is being used. So specifically, in patients where you're just sort of looking when they're symptomatic, so they developed leg swelling and then you get an ultrasound, it looks like the rates of venous thrombotic events is anywhere between 17 and 30%. There was one small study where they just routinely did ultrasounds on everybody, and their rate for venous thrombotic events was around 70% in that patient population in the ICU. Also, we are seeing arterial events, which can be things like MI, which we've discussed before, strokes, acute limb ischemia in the setting of peripheral embolization. And we're not quite sure about the incidence of that, but it's probably somewhere on the order of 2 to 6% of ICU level patients. Now, what's the mechanism? Well, as I mentioned before, we know that there is a coagulopathy and that it's common in critically ill COVID-19 patients. You've seen this panel with D-dimer before. And also we appreciate that it's associated with a higher mortality. I've mentioned that we are starting to have some appreciation that maybe it's not just about the coagulation cascade, but also potentially about platelet activation that is contributing to this prothrombotic state, based on the early autopsy series that I've mentioned before, showing both macro and micro thrombotic events, and this putative role from megakaryocytes in promoting thrombotic events in the affected organs. And so it's with this background that we've actually developed a randomized control trial where we'll address the options for therapies and prevention in this patient population. The COVID PAC trial is a trial that's being run by the TIMI study group, which I'm an investigator in, and then the Critical Care Cardiology Trial Network, which is a group of sites throughout North America who are collaborating to do studies such as this, based in cardiac ICUs. And this is being led by our chair, Mark Sabatine, myself, David Morrow, who's the PI, and then also in collaboration with hematology and pulmonary critical care at our institution. But it will be multi-center. We're including patients who are in the ICU and who have documented COVID-19, and we're randomizing them in a 2-by-2 factorial way, either to your standard prophylactic anticoagulation that any ICU patient would be on, or full dose anticoagulation. And this is obviously in patients who don't have an indication for full dose anticoagulation otherwise. And then for those patients who are not on antiplatelet therapy at baseline for some reason, say coronary disease, then those patients are eligible for a second level randomization to either clopidogrel or no antiplatelet therapy. And we're looking at efficacy, which is various elements that encapsulate venous or arterial thrombotic events, and then safety, which is bleeding. And we're very, very excited to hopefully at some point be able to have some, rigorous randomized data to be able to tell you how to manage and prevent events in these patients. And I will say that ours is one study. There are a couple other studies which are also ongoing addressing similar issues, all with anticoagulation, none with antiplatelet as of yet. But I think we will have a lot of data from several different trials at some point to inform how we manage these patients. So in conclusion, as you have seen, the landscape is rapidly evolving for COVID-19. There definitely is much to learn about the disease in general and about the cardiovascular complications, and that includes, really how often are we seeing these events? What is the severity? What is the reversibility? What are the long-term consequences? And how should we manage these patients? And I think the way that we're going to get to the bottom of this is with collaborative efforts. And again, also, necessarily much of the data we have so far is observational, and I think that's great. But as much as we can do rigorous randomized studies, I think that will best inform how we manage these patients. And so just as a plug for some of the efforts that we're making on this front, we're working with the American Heart Association, who has created a COVID-19 cardiovascular disease registry, a multi-center, so we can really gain the numbers to try to understand, again, what are the frequency and sort of all of the things that I mentioned that we still have to better understand in terms of cardiovascular complications. And then I've already told you about our critical care cardiology trial network, which, as I mentioned, is a multi-center network of cardiac ICUs across North America, and our efforts both in the COVID PAC trial, but then also just registry-wise, trying to have a better appreciation of what's happening with this disease. And then finally, I'll just show you this. This was a really nice example of collaborative efforts, something that it's the covidprotocols.org, which is a website that was developed and maintained by physicians at the Brigham and Women's Hospital, and it's available to anybody who wants it. And I will tell you, it was a very collaborative effort with individuals from really every division contributing, to things like the cardiology side, hematology, nephrology, neurology, and this is a living document, so it's updated. Infectious disease, importantly. It's updated as we gain more understanding of the disease. So I make a plug for this. It's available to you if you have interest. And so with that, thank you for your attention, and thank you for joining me through this journey. And obviously, please stay safe.